So we've been doing inductions. Why do we go on and on and on about contraception all the time? Why is it so important?
Don't get pregnant.
Stop you getting pregnant, yes. Any other thoughts about why I am so evangelical about contraception to the point of boring everyone in the universe? So having a baby in this country is the most dangerous thing any woman will ever do, unless she happens to be a bungee jumper or, you know, enjoys running out in front of buses or whatever. So having babies is great if you want babies, but they should be, every baby ideally should be wanted and planned. I know that's aspirational, but ideally. But we need to remember that pregnancy is risky. Pregnancy is far more risky than contraception. Having a baby, incidentally, is far more risky than having an abortion. And worldwide, every day, 2 jumbo jets full of women die as a result of pregnancy. And one of those jumbo jets was full of women who did not want to be pregnant. Okay? Now, if that's not a tragedy, I don't know what is. And of course, working in Tower Hamlets is not exactly the same as the worldwide situation, but it's not very different. And the sort of issues that mean that those women can't access appropriate contraception, things like access, being able to get hold of it, being able to get an appointment wherever you want to go, things like maybe not having the autonomy to decide what you're going to do about contraception, things like knowledge of contraception, things like poverty, actually are all here. So it's really important. Contraception is a really important public health issue. So we will bang on about it to the point of boredom. So what we're going to do today is we're going to talk quite a lot about those issues. We'll talk a little bit about actual methods of contraception and how they work. But mainly what we're going to be thinking about today is what are the barriers to more women being able to access the contraception of their choice at the time that they choose it. So we're going to be thinking a little bit about access in our departments, access in primary care. We're going to be thinking one of the big barriers to women accessing contraception is people being trained to deliver it confidently. So we're going to think a bit about training. And then we're also, in the little bit at the end, we're going to talk about new things in contraception, one of which is postnatal contraception, which is incredibly exciting and important. In terms of timing, timing is very tight, and Jane's going to be very strict with us, so she's going to be knocking me off here in a moment. So we are going to try and keep really well to time. We are going to finish on time. The Fitters Forum at the end will be a little bit shorter than it is on the programme, but it's still going to be there. So if you could be thinking a little bit about any cases you want to bring to the Fitters Forum during the course of the afternoon, that would be helpful. So, breathe. So what I wanted to do first was just tell you a little bit, and you may well know all of this, about what's been happening in our sexual health services recently. So, as you probably know, Public Health have recommissioned sexual health services all across London, and that's given us opportunities to review how we deliver our services and change them quite significantly. It's still a work in progress. We're very much mobilising this at the moment, so you will find that there's some things we don't know the answers to. They're not completely set up yet, but there's a lot of work being done and it's still going on. So work package 1 is what we think about as the patient-facing sexual health delivery part. And what we've now got, you may remember that we used to have main centres at the Ambrose King, at Mile End, at Barts, and then we had Newham Hospital, Whipps Cross Hospital, and then there were community family planning services in both Waltham Forest and Newham. That's all now been brought together, so we are now Barts Health Sexual Health Services, which is called All East. All East, yeah. It's called All East, and we're going to have all fancy brands and logos and all sorts of things. But the way it's structured is we have 2 centres of excellence. One is at the Ambrose King Centre, as we're used to. The other is in the SLG Centre in Stratford. Okay? Now, the aim is that those two services will be quite similar to each other, will provide everything for men and women that's needed, and that the staff will be able to work across both of them because they're going to work in the same way, largely. And then all three boroughs have also got nurse-led satellite clinics, which don't provide the whole range of complex contraception and sexual health, but actually do provide most of it, because we know that some women and men need to be able to access care nearer their home. So the Slg Center, I just can't say that whole big name. The Slg Center is the services from Whips and Newham, and also the community family planning services. And this is quite exciting for that area because it means it is much more integrated in terms of sexual health, the whole range of sexual health, than it was before. So our local service, the Ambrose King, which you all know, the opening times have extended. So 4 days a week up till 6:30, Friday up till 3:30, and we now have all day Saturday in order to make it easier for people to access the services. And that website...
Website's in the very, is on.
No, I'm just looking at that email address.
The advice email address.
It's the advice email address, is it? Okay, all right. So, and then we also have the satellite clinics. The Step Forward clinic is for young people. I don't personally know where all these places are, but I bet you do. So St Andrews, which I'm told is a lovely building, Mildmay, which is open during the week and on a Sunday, and then the Sylvia Pankhurst Centre here at Mile End is also a satellite. The Sylvia Pankhurst Centre, just to get my word in, still has the abortion service, the menopause service and the FGM service. That hasn't changed. So, I've just flashed some opening times up to you, but of course things change and adjust, and what I would say to you is please, please, please keep an eye on our website. So if you're with a patient and you want to be able to tell them how to access the service when the service is open, go to the website with them and then you can have a look and see whether anything's changed. So in terms of accessing the service, because as we know, access is really, really important, isn't it? You know, contraception's easy, people are difficult, access is difficult. So we still have a walk-in service, okay? We have a slot system, people don't just walk in and wait for 8 hours. So if somebody walks in, they will be given a slot that day. If they can't be given a slot that day, the nurse coordinator will triage to see whether it's urgent, and if they can't be seen that day, they'll be offered a slot the next day. And that's for the whole range of contraception and sexual health issues. They can also pre-book slots through the website, and this, I would say about half of our patients probably do this. So you can book slots for anything to do with infections or contraception, for follow-up, for repeat pills, anything like that. And you can also book IUD and implant slots this way. What people can't do this way is book complex contraception. So if you've got a patient that you've got a problem with and you need some help or support or something different to happen, this is not the route, okay? But this is the route for patients. They can walk in or they can book through the website. Now, for you, we are in the process of developing a contraception referral system. I don't know, I was going to ask you, but I don't think time will really allow. I don't know what you've done up to now, if you've had an IUD that you couldn't fit or an implant that was too deep to remove, or someone whether you weren't sure whether they were safe to have the pill or not. We do still have the Sylvia Pankhurst email address. The phone number often isn't answered. We don't have as many back office staff as we used to have. Sometimes patients will just walk in with a letter from the GP, and that's fine, but they may well find that they see a practitioner who says, I can't deal with this, and will then book them in for another clinic. So long as that's what they're expecting, that's okay. But we're going to be improving that, and we're going to be developing a referral form which you'll be able to use on EMIS, which will speed all of that up to get the patient into the most appropriate clinic. You will all know that we're moving over to e-referral for most clinics across the hospital. Now, the menopause and the FGM clinics will be on e-referral. These clinics won't be, because we have a separate IT system. So you won't be able to access any sexual health or contraception appointments through e-referral. So otherwise, what you can do until we've got that set up, and for everything across GU, you can go to the website, help them to book an appointment and give them a letter to bring with them. That's okay. You can give them a letter, then remind them to take the letter, show it to the receptionist, because the receptionist can always show it to the coordinator, and then we can get the patient booked into the appropriate clinic. And there is a referral form for GU issues, so infection issues. Okay?
What's the wait? Last question.
Yeah, no, go on.
Wait time, because I haven't done it for ages, but wait time for coil fitting on the online thing was like 2-3 months in.
Yeah, it's been a real problem, and we've been doing a lot of quality improvement work trying to reduce the wait time for IUDs.
Because only some of the, online it might be a wait time. It's not that there's a wait time, because for the online, for IUDs, they only show up, you can only put them 2 weeks before.
There's never any slots.
No.
Yeah, and there's never any slots, but people can walk in, or they can call and book.
So the wait times have been long for IUDs. They are getting a bit better. More and more of our nurses are now fitting IUDs. So emergency IUDs can always be fitted on the day in a walk-in clinic. We have IUD slots on a Saturday. So we have a daily IUD clinic and a daily implant clinic. And actually some days we have more than one. So mostly they'll go in there. They can also be done on a walk-in, and we have some pre-booked slots on a Saturday. So if they can't book online, their best bet is to come in at the moment. The biggest issue with this is that people often don't turn up for their appointments. This must be very familiar to you. So people will book an appointment in an IUD clinic and they don't turn up. So if we've got a practitioner expecting to do 5 or 6 IUDs and maybe only 2 or 3 women come, then this is a problem. So what we're trying to do is to improve the information that we can give to people beforehand. We have tried the nurses ringing people beforehand to see whether they're going to come, but that's actually quite difficult. We text them reminders, but we're still trying to think of ways that we can use those clinics more effectively. So I suppose if you do send somebody in for an IUD and they end up with an appointment, if you could maybe stress that it would be really, really good if they come, that would be helpful. Yeah. And then just to remind you again, as always, if you've got someone newly diagnosed with HIV, you don't do any of those things, you ring this number and we'll sort it out. To talk to you about something which is really, really important and really exciting. So let's have a look at Asha. Okay, so Asha is 35, she's got 4 children. The oldest is 10, the youngest is 6 months, and the last 2 were born by caesarean section. She's diabetic, she's obese, and she had hypertension in her last pregnancy. She comes in to see you to discuss contraception, okay, but she's late with her period. You do a pregnancy test and it's positive. What do you think about Asha? What does this make you think? What does it make you feel?
Distressed.
Sorry?
Distressed.
Distressed, yep. What else? How often in a week do you see Asha? Sorry? Well, if I said to you that in the termination of pregnancy service we see Asha probably 3 or 4 times a week, okay? There are risks, aren't there, for Asha if she continues this. If she continues with the pregnancy, she's looking at her 4th caesarean section, which is, I don't know how many of you have ever done a 4th caesarean section, but it's a really difficult operation, particularly in someone with a BMI of 40. She's going to be hypertensive in this pregnancy, so this is going to be a seriously high-risk pregnancy, isn't it? So Asha may want to continue with this pregnancy, or she may decide that she's going to have a termination of pregnancy, which is also not going to be particularly easy. If we've caught her in time, she would be much safer with an early medical abortion than a surgical procedure, due to her BMI apart from anything else. But she has got, it's only 6 months since that last caesarean section, so we would be concerned about the risks of scar rupture. We're going to be concerned about the risks of thrombosis. So this is a high-risk pregnancy, and now it's happened. It's going to be risky to have a termination, and it's going to be risky to have a baby. Never mind the fact that it's distressing for her to have to make that decision. So this is a really, really common situation, isn't it? Now, if we go back in time to Asha, so I'm going to assume that all her 4 pregnancies were planned, and I'm going to assume that she had an elective caesarean section with her 6-month-old. What could we have done differently? At what point in the procedure could something different have happened to prevent this situation, do you think? She could have been offered a sterilisation at her last caesarean section. I'm going to tell you that she was offered it and she refused. I'm sorry? At the 6-week check. What could have happened at the 6-week check?
Discuss the contraception, especially the LARC.
Okay, so we could have discussed contraception, specifically LARC. Yes. What do you think she might have chosen for contraception if she'd talked about it at the 6-week check? Who was that? Okay, and absolutely, you're absolutely right. There is a very high chance that Asha would have chosen to use condoms. Actually, she was using condoms, mostly. So she might have chosen to use condoms. So let's go in with the most difficult bit. So Asha is in your surgery. Okay, you're having this conversation with her at her 6-week check. All 4 kids are there. The baby's crying. And she says she's just going to use condoms. In the real world, what are you going to do? Come on, we're all in this. We know what we're going to do. What are we going to do?
Come back next week.
Come back next week without all those children. Find someone to babysit for them, yes? So you might give her more time and more space. And what else might you do if you're going to tell her to come back next week? You might give her some leaflets, some information. What might you be saying to her? Why should she come back next week? She's quite happy to use condoms. Okay, so you're going to go 2% failure rate. I have to say, I think that's really optimistic. But she is 35, she's got 4 children, she probably doesn't have sex all that often, maybe, I don't know. But, so yes, so you'll talk to her about the failure rate of condoms, you'll give her some leaflets about other methods of contraception, and you'll talk to her about the risks of pregnancy. Okay, that happened, she didn't come back. Okay, didn't happen. So what else could have been done at that 6-week check? Instead of going, yeah, condoms aren't great, let's think about something else, come back and see me next week. What else could you have done? You could have started on the pill. Which pill? Progestin only, because this is not really a candidate for the combined pill. Being diabetic is not a problem. Being obese is not necessarily a problem. Having had hypertension in pregnancy is not necessarily a problem, but put them all together and her risk of thrombosis and heart disease is too high on the combined pill. So yes, you could say to her, I know you haven't decided about your contraception yet, but actually you could be pregnant any time from now. So why don't you start on these mini pills for now and then come back and talk to me next week about what else. She's not breastfeeding. I've just decided. Yes, so she could go for the mini pill. What else could you do? And also, at that 6-week check, she hasn't yet had sex. Yes, you could put an implant in, couldn't you? You could put an implant. So if we pretend now that we're at the 6-week check with all the children there, you could put an implant in. You could. Could you put an IUD in? Or an IUS?
Yeah, that's probably not a 6-week check. I mean, there are time constraints. But we might be struggling a bit.
Yes, so technically she could have had an IUD or an IUS at that 6-week check or shortly afterwards, but there's a lot of children in the room, so in reality you're probably not going to, but you could. Now, so there you are at the 6-week check, and she's saying, but I want to use condoms, I don't really understand what the problem is. Who could have made your life easier at that point? Apart from Asha and her husband. But if you think of all the people that Asha saw when she was having this baby, who could have made your life easier? The midwife. Yes. Or the health visitor. And actually extraordinary, when we talk about this, we don't really talk about health visitors very much, but that will come. Or the person that did the caesarean section who maybe might have really tried to get her to understand that the risks of a forced caesarean section for her are very great. So you're there at the 6-week check, not the ideal time to have the conversation, but at least she's there, but all those people could have made your life easier. But that didn't happen. So here she is now, and she's pregnant, and she's 7 weeks pregnant, and she's probably going to have an early medical abortion. So what should we do now? What should I do in the abortion service in terms of helping Asha not to get pregnant again until she's ready, maybe? So what could she have at the termination? Yes, she could. And in fact, that's really helpful that you said that, because if she has a surgical termination, which I hope she doesn't, then we could, at the time, couldn't we, either a copper coil or an IUS. If she has an early medical abortion, we will keep her in at Sylvia Pankhurst to be looked after by our nurses, and we could fit her IUD or her IUS on the day. So she'll pass the products, we'll do a scan, show that the uterus is empty, put the IUD or the IUS in. Okay? Slightly higher risk of expulsion than there would be if she hadn't been having a termination, but not very much higher, and at least the device is in. If she didn't want intrauterine contraception, what else could she have? Implant, which we will also fit on the day as part of the termination. Would you give her a depot? Would you give her a depot, Jill?
Because she's big and diabetic, arterial, hypertension. I'm not sure. I think I would, and then I'd probably remember I should have talked to that.
So the guidance would probably say that the depot would increase her risk of cardiovascular disease. I don't think the evidence is very clear on that. But the other issue is, although the evidence is really dodgy about whether depot causes weight gain, but if anything's going to cause weight gain, it's going to be depot, and she's not the woman that you want to put on any more weight. So if she absolutely wouldn't have anything else, I would say it's probably a UK MEC3, and I would probably give it, but only if she was really linked in with a diet and weight loss program. And one of the things you can all do, which I can't do yet, is social prescribing, isn't it? Which I think is very exciting. So if she has her termination, she will, I promise you, go home with some contraception. But what we're doing at the moment is trying to make sure that this situation arises as infrequently as possible. Sorry, where's my clicky thing? Thank you. Oh. Sorry about this, just, well, I haven't got too many slides, isn't it? Right, so what's happened recently is that the Royal College of Obstetricians and Gynecologists have been doing a lot of worldwide work in terms of reducing morbidity and mortality as a result of childbirth, and as a result of pregnancy, in fact. And in those projects, which are largely at the moment in South Africa and Tanzania, one of their focuses is on postpartum contraception. And then we began to realise that if we can make postpartum contraception work in Tanzania and South Africa, we really ought to be able to do it here. So there was a guideline produced at the beginning of last year, and this was produced by the Faculty of Sexual and Reproductive Health, but it's badged and blessed by the RCOG, by the Royal College of Midwives, and I believe by the Royal College of GPs as well. And actually, politically, it was really quite difficult to get that piece of work done. But what this guideline says, basically, is that any service that looks after pregnant women should be able to issue all appropriate methods of contraception. It's really aspirational, but it means that maternity should be able to issue, provide, administer all appropriate methods of contraception, as should gynae when we manage pregnancies that didn't go to fruition, so miscarriages or whatever, as should abortion services. And of course, that would make life so much easier for women. It's not an easy thing. When somebody's just had a baby, you know, how long do you stay in after a normal delivery now? About an hour? You know, I mean, you've just about got time to call an Uber, haven't you? But so the point is that we should be able to issue this contraception, but just after the delivery is not the time to talk about it. It does also say that if that service can't issue the contraception, they should be able to have a care pathway through to a service that can. So what this guidance says, and it's important that this is not just for ASHA, this is not just for high risk women, it's for all women. So what the guidance says is that at around 28 weeks of pregnancy, and I was interested that you were saying you do it at 34, 36 weeks of pregnancy, at around 28 weeks of pregnancy, the midwife should be having a conversation with this woman saying, what do you think you're going to do afterwards? It's a really good idea to leave a couple of years between this baby and your next baby, at least. So you need to think about contraception. What would you like to do? Now, what's happening at Bart's at the moment is we have started this. This is being led by maternity. There's a post-CCT clinical fellow called Emma Avery who's doing a lot of this work, along with Susie Crowe, who's the labour ward lead. So what we're doing is we're encouraging our midwives to ask that question and to get the woman to make a plan for what she wants to do. Now, of course, commissioning makes everything very tricky because maternity is commissioned by you guys. LARC, as you know, and we are commissioned by Public Health. Now, you all do standard contraception as part of your basic contract, but people seem to conveniently forget that. So there is, at the moment, a problem with the funding of our midwives writing prescriptions for pills or our SHOs writing prescriptions for implants. At some point with joint commissioning, we will solve this. And actually, it's one of the things that the joint commissioning group is looking at the moment. So hopefully, we will see things improve. But at the moment, if this woman says, I'd really like an implant fitted on labour ward before I go home, then she will come to you and ask you to prescribe that implant. And it would be really helpful, both for the woman and I would say for you, if you could do that. And then the idea is she brings it in with her bag. When she's had the baby, someone will fit the implant for her and she'll go home with ongoing contraception.
And if you put it on your Women's Health template, Jane and I think you might get paid for it as well. Because it's you're providing contraception below.
Okay. Well, we could talk about that because that would be quite helpful. So the same goes with depot. She can bring her depot in and we can administer it. The same will more and more in the future go for the IUD and the IUS. You can prescribe her progesterone-only pill or her combined pill so that she's ready to start. And I'll talk to you in a minute about when you should start those things. But so at the moment, this is shared care, all right? We will discuss it. It would be really helpful if you would discuss it when you see her as well. You do the prescription, we'll administer it on labour ward. And then the problem with ASHA will happen less and less and less. Okay, is everybody sort of reasonably clear on that? Yeah? So, the second link on here is to the patient information leaflet that maternity have provided for their patients. So they will be giving this leaflet to all of the patients when they come through. But you can also download it from the Barts Health website. And it just goes through the information about all the methods of contraception and when you can start it. So if the women can start to read this when they're sort of 28, 30 weeks pregnant, then they've got plenty of time to make a plan. And of course, we've got to remember babies sometimes come early, don't they? So in fact, if this woman has the conversation at 28 weeks and then she has an emergency caesarean section at 31 weeks, then she's already organised. So that's why we need to do it reasonably early. So let's think about the methods of contraception and think about when we could start them. So if she decides to have the mini pill, when should she start? Well, actually, when do you make your first egg after a baby?
5 weeks.
Any advance on 5 weeks? 4 weeks. Okay, 2 weeks after a miscarriage, 2 weeks after an abortion, 4 weeks after a baby, you make your first egg. Okay, so when do we need to have contraception in by? 3 weeks, day 21. Now it can be earlier for a lot of methods, but we need to have something working by day 21. If you're breastfeeding, are you covered for contraception? Yes. You can go on, go on.
Not unless you're very
Not unless you're very breastfeeding. That's absolutely right. Fully breastfeeding, no supplements at all, not even water, no periods, and less than 6 months. Okay? But that doesn't mean you're not allowed to use some other form of contraception. It just means that if you come in asking for emergency contraception, you probably don't need it. So, first egg at 4 weeks. So, let's pretend that Asha's on labour ward now. She had a caesarean section yesterday. She wants to go on the mini pill. When would she start? Now. She wants a depot. When would she start? Now. We used to, yeah, okay, we don't want to give a depot, that's true, but if she was going to have depot, she would start it now, okay? She wants an implant. When should she have it? Now. Yes, absolutely. She wants the combined pill. She's not going to breastfeed. When should she start it?
4 weeks.
3 weeks, day 21, ready for that first ovulation, okay? She is going to breastfeed, but she wants the combined pill. This is new. When should she start it? I mean, we're not going to give her the combined pill anyway, are we, Asha? But let's make her suddenly younger, slimmer and less hypertensive. And she wants the combined pill. When should she start it? Well, yeah. Now, it used to be 6 months. We used to say you can start the combined pill after 6 months when you're breastfeeding, and that will be okay. And it is about establishment of feeding. The guidance now is 6 weeks. Okay, so I'm not necessarily expecting you to remember all of that, but it is in both of these guidelines. So, we're Asha again now, and she's Asha being Asha. She is on the postnatal ward, the SHO comes around to see her. When should she have her IUS fitted? Yeah, go on. You're right.
After the cesarean section.
How long after?
The theatre.
Yes, absolutely. So, the answer to when Asha should have had her IUS is yesterday at her caesarean section. So, IUDs and IUSs can be fitted at caesarean section. We have started doing it on maternity. There is a higher risk of expulsion, but this is really important for you to know. At the moment, my obstetric colleagues are starting to do IUDs and IUSs, they'll mostly be IUSs I think, at elective caesarean section, particularly for high-risk women. But once we get that established, then we'll find it will be everyone who's having an elective section will be offered it, and then we'll find that, well, why can't we do it at emergency caesarean sections as well? And actually they can be fitted immediately after delivery of the placenta as well, but we're not starting that just yet. But more and more over the next 2 or 3 years, you will see women who have had intrauterine contraception fitted at the time of caesarean section. And this is important because what happens is, when, I don't know if any of you have seen the video, but when you put an IUD or an IUS in at the time of caesarean section, you deliver the baby, you deliver the placenta, you put the coil in, you feed the threads down through the cervix, and you don't cut them. So the threads will be really long. They may be long enough that they actually will come out of the vulva. Okay? Now what the women are told is, if the threads are so long that they come out of the vulva, you can very carefully cut them, but you must have a 6-week check. And this is really important because what our team need to know and what you need to know and what your practice nurses need to know, normally if a woman with an IUD or an IUS came into you and the threads were really long and hanging out completely, you would assume that that IUD or IUS was falling out. It's not the case in this situation. They need a scan at 6 weeks. So the care pathway that we've set up is when they fit this, they email me, I see them in one of my complex clinics, do a scan and cut the threads down to the appropriate length. Okay? But we know that some of these will expel. So I saw a woman the other day, in fact, who she'd cut them and then they'd come down again and she'd cut them again, and when I examined her it was in the cervix. So she now hasn't got an IUS in anymore, but she has got an appointment to come back and see me in a couple of weeks for a refit, and she was very like Asha. So that's something that you'll see more and more, and we really need you to know that it's not these threads are long, I'm going to take this coil out. It's what you need to do is cut them to make it bearable, ring me, email me, ring Sylvia Pankhurst, email Sylvia Pankhurst, I don't care how you get in touch with us, and just say that this lady needs to come in for the complex contraception clinic. Okay?
Getting in touch with Sylvia Pankhurst is quite difficult because now there's a single point of access, which
Yes.
ladies requiring terminations are also told of that.
So the single point of access is only for the abortion service. And it's partly about changes to admin, but it's also, it's really so that they can ring 24/7. rather than it was getting so difficult for women to get through on the phone that the single point of access, I think, is a better answer. But it is only for the abortion service. The best way to get in touch with Sylvia Pankhurst is, and this is where I'm going to be embarrassed and I'm not going to be able to remember the email address, but Sylvia Pankhurst still has an email address, or you can use the email address that we've given you for all the other referrals, or you can email me. But the Sylvia point of access is only really for abortion bookings and abortion complications. So, that's postnatal contraception. And the idea is that each of us will have a chance to have a conversation with a woman. So 28 weeks, subsequently in pregnancy, on labour ward, on the postnatal ward. Hopefully we'll get the health visitor to be able to have these conversations as well. And then by the time you get to be doing your 6-week checks, you either find that somebody's already started on contraception, or at least she's really thought about what she wants to do, and it should make your life a whole lot easier. I've got any questions about that? It's very exciting, isn't it?
Is there a reason of keeping the thread so long? Or
yeah, no, that's a good question. It's because it's done from above. It's because it's done from inside the uterus. So if you were going to cut the threads, then you would then have to go into the vagina and cut the threads, and that would increase the risk of infection. Also, of course, you've got a big uterus at that point, so it allows the IUD to find its position, and then you can cut the threads to the appropriate length later.
And if you're putting them in post-normal delivery,
Yes.
so they're not gained yet, what about retained placentas and bits and pieces? Will they just...
That's a good question. I think they, as I say, we haven't started it yet. I think they would need to check that the placenta was complete first, but they should be doing that anyway. That is the concern. That's Emma's concern about doing that, is whether there's an increased risk of infection. Obviously, when we fit, everybody that has an abortion, we give metronidazole PR to, but you don't want to be giving metronidazole to someone who's just had a baby and might be breastfeeding, because that won't help with the breastfeeding. So that's the infection risk is our worry at the moment. So at the moment, how long after a normal delivery can you fit an IUD or an IUS? 4 weeks. 4 weeks. It feels quite early, and you can fit it at 4 weeks post caesarean section as well. Used to be 6 weeks. Since the NICE guidelines, it's 4 weeks. It does feel quite early, but it's worth doing. It may become earlier, so the guidance is basically either immediately or at 4 weeks, because it's thought that the risk of perforation will probably be higher if you do it in that time when the uterus is actually involuting. I feel like there's more I should have said about that, but I can't actually think what it was. No? That's fine. I think that's everything I wanted to say. Has anybody else got any questions about anything?
No, I haven't any questions, but it occurs to me as practice nurses give flu and pertussis vaccination to pregnant women, and that's another opportunity for discussing, because that's around 20 weeks, although that's even earlier than we've talked about, but it's another opportunity, and often the nurses are the people who they may see ongoing in the practice for contraception, and may have seen.
And you may well be the people that do the bulk of the contraception work in your practice, so that's a really good point. And it's all part of this life course approach, isn't it? So when somebody's pregnant, we don't just think about the pregnancy, we think about the next one, we think about her health, we think about, you know, when did you last have a smear? So, you know, it's about trying to think about women's health in the round, and I agree with you. I think the practice nurse is probably a really good person to do that. Especially people that have done their SRH essentials. Anything else, any thoughts? Because this is quite new, this postnatal contraception work, and actually in East London we are a bit ahead of the game. So we're quite proud of the fact that we are probably further ahead than a lot of maternity units. And yeah.
I feel as a practice nurse quite uncomfortable when I get patients who come for their 6-week check after having a coiling. And they say, oh, I just come to see you for you to make sure that my coil's in the right place and to see the threads. I don't know if anyone else feels funny, but like, the threads can be different lengths because someone might have shot from a different size, and I never feel like I can actually say, yes, your coil's definitely in the right place and you don't have to worry.
I think that's a really good point, and I think we've got, since we've had ultrasound, we've realised how much we don't know about coil placements. So in the old days, before we used ultrasound so much, you'd have a look, you'd see some threads, you didn't see a device coming through the cervix, and you'd say that's fine. With the recognition that you didn't know where in the uterus that was. Then we started scanning everybody, and we started realising that some coils were at the fundus and some coils were lower down. But we don't know what that means. There's no evidence actually that where the IUD or IUS is in the uterus makes any difference to its contraceptive efficacy. So we're now in a position where we get women coming in with scans saying my coil's in the wrong place, I need to have it replaced, but there's not actually evidence that we do. So actually, if it's low down in the cavity but she's not having pain, then it probably doesn't need to be changed. What we should be doing, and we're not, and we should be, is we should be making a note of how long we're cutting the threads. Now, we'd have to think about how that information would be transferred to you, but probably what we should be doing on the little card that we give women to say this is what sort of IUD you've got and this is when it needs to be changed, maybe what we should be doing is writing on that card threads left at 2 centimetres, threads left at 3 centimetres, because you're right, we all leave them at different lengths. And when I've worked in smaller services, I would be able to look at a coil and tell you who fitted it depending on how long the threads were left. Now there's too many of us, so I can't do that. But I think that's a really good point, and I think it would be a really helpful thing. And then you would just look at the card and you'd go, oh, okay, the threads were left at 4 centimetres, so this is all right. At the moment, if it's somewhere less than about 4 centimetres, you're probably all right. Don't poke around in the cervix, and I'm sure you wouldn't. But obviously just make sure you can't see a little white plastic end coming out of the cervix. But I think that's something we should be expecting our team to do.
How long 1, 2, 3 or 4 centimetres is, especially at the other end of the speculum.
Well, I'm sure we can work it out. So, yeah, that's a really good question. Thank you. Any other thoughts, any other questions? We're going to go on and do a Fitoforum in a minute, but...
That can be a bit difficult to judge, though, because sometimes it's wrapped around the neck of the womb,
yes,
and you will not be able to...
That's also true. And I think you need to go with it clinically. So first of all, why is she coming in to see whether it's not in the right place? So is she just worried, but she's not got any symptoms, in which case actually, so long as the threads are somewhere between visible and 4 centimetres, then it's probably okay. Or has she got pain? In which case you've got to think, well, why has she got pain? So what's the history of the pain? When does the pain come? Is it with sex? Is it all the time? Is it when she's constipated? So then you take a history of the pain and have a think about whether you think it's with the IUD. Then I don't know if you do bimanuals. So if somebody's got pain with an IUD, then actually to do a bimanual and see if the uterus is tender is helpful. And then you're thinking, well, is it PID? Has she got a bit of endometriosis? It depends a bit how long ago was the IUD fitted. So if it's 2 or 3 weeks after the IUD is fitted and she's got pain and some tenderness, then you would probably give her some antibiotics. And a pregnancy test, that's a very good point. And of course, don't forget, if it's the first time it's been checked since the fitting and you can't see the threads, what are you going to do? Scan. Because if the threads have never been seen, then you can't exclude a perforation. If the threads have been seen, if she's had this IUD in for 5 years, she's always felt the threads, now she can't feel them anymore, then you need to check that it's not run away, it's not fallen out, but it's the first one, the first check after fitting, that is the one that excludes a perforation. And I think you said, didn't you, Barbara, that you don't routinely do first checks anymore, and that's right. We fit it, we say, right, what I say is, after 6 weeks I want you to do your own IUD check. So what you do is you think to yourself, am I happy with my periods? Can I have sex without any pain? And can I feel the threads? If the woman herself can't feel the threads, then she'll come into you for you to feel the threads. So long as you can feel them or see them, she's all right. But if you can't, if they're not there, she needs a scan to exclude a perforation. Sorry, I think you were next, weren't you?
If after the scan, that the result comes that the coil is in its place, is in situ, and no threads, after reassuring her, do you still call her back anytime again?
No, I wouldn't. I would just say to her, look, it's fine. The threads may or may not come back. They're just tucked up into the cervix. When you need to have it changed or taken out, you'll need to go to a specialist clinic to do that, but they'll be able to do it perfectly easily. So no, I wouldn't do any more after that. Sorry, you?
scan if we've got concerns about the coil?
Okay, so if the patient is asymptomatic and doesn't need a procedure, so she doesn't want it taking out, then you would just refer to the ultrasound department in the normal way for a transvaginal scan. But you would tell her to use some other form of contraception in the meantime. If you've got somebody who wants a coil removed, or maybe someone who's got pain and you can't see the threads, then send her to me and I'll scan her. It's just I can't do all the scans and I'm not an ultrasonographer. Sorry, I'm going deaf, I think.
As a practice nurse, some things that we've been asked before, like people come in, you triage them, and they say, oh, I don't want my coil anymore. I know you need training to put the coil in, but do you need training to take it out?
Well, I think that's a very good question as well. There's not a training scheme and a qualification for taking it out, no. And in our service, I don't think we train our nurses to take them out, they just do it. So I guess it's something to talk about within your practice, but actually pulling on the threads and taking it out, no, that's entirely straightforward. There's a couple of things you need to know, of course. If they've had sex in the previous week without some other form of contraception, she may be pregnant, and maybe what she wants. So if she doesn't want to be pregnant, then she should have had no sex or no unprotected sex in the previous week. And also, and this is something I say to our nurses a lot, think about why is she having it taken out. If she's taking it out because of pain, then you need to think about why she's got pain before you take it out. And if she's had it, if it's a Mirena, which was fitted by gynecology for a gynecological purpose, then you need to really think, am I going to stop this gynecological therapy, which is her IUS? You know, is that something I want to do? Is that something I'm qualified to do? Is that something the gynecologist is going to be really pleased with me for doing? So you do need to think a little bit about why it's coming out. But if it's a straightforward woman, you know, I'm going on the pill, I've already started, or I'm having it taken out because I want a baby, and I've thought about my preconception care, and I'm on folic acid, and my BMI is less than 30, and I'm not drinking alcohol or taking illicit drugs, then yes, by all means, take it out.
Of us doing prescriptions to take over treatment. I think we only get, if we're buying the coils, we only get your money back if you're fitting them, I believe, not as a coil fitter. Otherwise you have to do a medical test. So I think it will be the practice being out of pocket.
I think, you know, the financial side of it, I did check with maternity that they were happy for me to talk to you about this. The financial side of it is tricky, and it needs to be sorted out. Which of you are involved with commissioning? No. I am going to a meeting straight after this, and we are talking about it at the Joint Commissioning Board, but it's really important to ask these questions, I think. And I don't know, it's easy for me to say, isn't it? Well, you know, out of pocket. It's not very much. It's better than Asha being pregnant again. But obviously, I'm sure you've got rules and, you know, guidance and all the rest of it. We need to think about this.
Endometriosis.
The other thing is, sorry to interrupt you, we are being fairly flexible. So if somebody really needs an IUD or an IUS and it's not in her overnight bag, we'll get one from somewhere. So it works both ways.
Treatment of endometriosis with coil, and then also I want to talk about one stop people phoning up to say, I want an abortion, here's my number and my name, and then phoning back.
Yes. So the treatment of endometriosis is frustratingly non-evidence based, but when you've been fitting coils for a long time, we know that we see some women who have pain and tenderness both post-fitting, sometimes some bleeding. They haven't got PID, they haven't got chlamydia or gonorrhea, and in the past we've always, in a very non-evidence based way, defined it as an inflammation of the endometrium and endometritis and treated it with a week of doxycycline. I wish it had an evidence base, but it does work. So that's what I would do in that situation. The single point of access is, so I'm not saying it's a perfect solution, but it felt like a better solution. So this is about phoning up and booking TOPs.
Well, I booked when I found out that you had to do something with access and had the patient in front of me, the sort of Pankhurst and they wouldn't speak to me because I wasn't the patient. And then they're expecting the patient to talk to some stranger on the end of the phone and tell them they want an abortion. And I thought, this doesn't feel right.
Yeah.
The Pankhurst used to be very skilled at doing this kind of things, and the girl at the end of the phone was not.
Well, that's interesting. It is true that the administrators that we used to have at the Sylvia Pankhurst did it all the time and were very skilled. They're not there anymore. We've done quite a bit of training with the single point of access team about non-judgmental, about confidentiality. They do have the advantage that they can speak different languages. They have the advantage that someone can phone at 2 o'clock in the morning if they need some privacy. But and actually you're right, they have been told that they can only talk to the patient because we don't want to be booking abortions, you know, somebody's boyfriend or husband or mother. You know, in the normal way of things, we would normally only talk to the patient. But I do think that we could say to them, actually, if it's the GP, then of course. So I will feed that back. Was she not helpful in terms of not being kind and polite or not knowing the information?
Not knowing information, I wanted the woman to get an appointment quickly so she had the option of medical examination.
Okay. So again, so then what happens is, frustratingly, you see the single point of access people do work on the community contract, which means they work with EMIS. Because all the physiotherapists and people like that work with EMIS. We don't, our patients are booked on CRS. So they can't book an appointment there and then. So all they can do is email through to Sylvia Pankhurst and we pick up those appointments in real time, Monday to Friday, first thing in the morning. So then she will either get a phone call back. It should be possible for you to say, look, could you make a note on your referral that? It sounds like we need to do another training session with them, actually, and we haven't done one for a few months, so that's really helpful, actually. I mean, I suppose the other thing, I keep saying this, but if you've got an issue about a particular patient, particularly if you're worried about a particular patient, email me. And if I'm not there, then it will usually say who else you can email.
I think the other problem is we have such problems with single point of access, the district nurses not getting messages through. To phone up single point of access and trust that this woman is going to get her abortion appointment is a huge leap for me.
Okay, well that's really interesting because it's sold as all very efficient and shiny. I think you can say to her that she should have had a phone call back within 24 hours, a phone call or a text. So if she hasn't heard within 24 hours, I would suggest she phones again.
Should we formally have a LARC that is for now?
Okay. Has anyone got any questions that aren't LARC?
That aren't?
Aren't, yeah.
I have a very important question I really want to know the answer to.
Okay.
I've got a patient who experiences hair loss on progesterone, so they've tried implant, they've tried IUS, they've tried Depo. They've now tried the COCP, and it's month 3 of them, and they're starting to have hair loss from that too. And they want to know, is there any combination? They won't go near a copper coil because they get really heavy periods,
Okay.
painful periods, and they don't know what to do next. But the hair loss is really stressing, and they want to know whether is there a way of getting a combined pill with a reduced amount? Like, is there a less amount of progesterone to get a combined pill that would work better for them?
Hair loss is really difficult because actually we don't really know whether it's the progesterone, whether it's the estrogen, whether it would have happened anyway. And it seems that hair loss happens with hormone changes rather than any absolute hormone amounts. I presume they've checked that she's not anemic and that her zinc levels, I would have her on zinc supplements because all women are short on zinc. The only thing, is it male pattern baldness or is it across the whole of her head?
Random, she said, like when she's brushing her hair, it just clumps of, like she doesn't actually have patches, but it's
just everywhere, yeah. So if it was male pattern, then I would say Dianet. It might be one of those situations where it might be worth trying a natural estrogen pill like Clara or Zoli. It's expensive, but yeah. They're good pills and they would be used a whole lot more if they weren't so crucifyingly expensive. But it might be worth trying that. Otherwise, I think I'd send her to an endocrinologist, actually.
Specialist, the
estrogen pills we can't. Are we allowed to prescribe them or are they specialists?
You could send it to me, or Jill, or Anne McGregor. Actually, that's not a bad idea, because then we can have a look at whether specialist things would work. Yeah, but with a letter.
Yeah.